Okay. Hello, everyone. Welcome and thank you for joining us on the South Sudanese Women Intellectuals Forum. My name is Dr. Anne Lomole. I am a pediatrician and an infectious disease consultant, and I will be your moderator for this session. Today, we will be discussing the state of healthcare in South Sudan. According to the WHO, health is defined as a state of complete physical, mental, and social well being, and not merely the absence of infirmity or disease. Healthcare is a human right. However, for many low and middle income countries, this is not the reality. South Sudan is not an exception. Due to the many years of civil war and recurrent political instability, allegations of corruption, and lack of leadership in healthcare and other sectors, health services have not only deteriorated, but the few that are available are not accessible to most of the population. Human resources for health are inadequate or lacking and demotivated due to poor pay and lack of properly equipped facilities. The population, therefore, suffers the brunt of these inadequacies, and mortality and morbidity due to easily treatable and preventable diseases continues to be high. On the 7th of April, the world celebrated the World Health Day, and the theme was building a fairer and healthier world. However, the reality for the people of South Sudan is nowhere near the expected targets. Health affects various sectors, including the economy and development, and without a healthy population, other sectors then lag behind. If we as the people of South Sudan would like our nation to progress, there must be investment in healthcare in terms of provision of services, investment in human resources for health, development of infrastructure for health, and increasing financing for health, and ensuring visionary leadership in healthcare. Our panelists today will discuss some of the issues, challenges, and opportunities in healthcare service provision in South Sudan. They will also discuss recommendations and possible solutions for the same. We hope that through this discussion, we'll be able to dissect some of the issues affecting the healthcare sector in South Sudan and possibly also give some suggestions on possible solutions. We would like to thank all our panelists today for joining us and taking their time to participate in this discussion. We also thank the audience for joining us today. We would like to thank the UN Women for supporting us, and also Aisha, who is behind the scenes with technical support. We are currently streaming live on Facebook and YouTube, so feel free to share this discussion on all your social media platforms, and do not hesitate to ask any questions on our wall. We will try and answer as many as we can. Today, we are fortunate to have the first all-male health panel on the South Sudanese Women Intellectuals Forum. Welcome, gentlemen. I would like to thank them once again for joining us, and I will go straight into the introductions. So I would like to first introduce Dr. Bono John, who is an obstetrician and gynecologist. He attained his Master's of Medicine in Obstetrics and Gynecology from the Faculty of Medicine in the University of Jazeera in Medani, Sudan. He got his MBCHB in Medicine and Surgery from the College of Medicine in the University of Alexandria in Egypt, and did his basic education in the Republic of Zaire and Central African Republic. He has held various posts, including as an advisor to the COVID-19 task force. He has also been a director in the Catholic University of South Sudan Yambio campus. He was also director of St. John's Health Services Training Institute in Zara, and a director general at St. Teresa Zara Hospital. He has been a project manager in comprehensive obstetrics, emergency, and newborn care at Tombura Hospital with the Health Pool Fund. He was a former dean of the College of Medicine of the University of Juba, a lecturer and an assistant professor. He was also the State Minister of Health in Western Equatoria State from 2012 to 2015. He has had many years of experience both in managerial positions, in academic positions, and in clinical work. Welcome, Dr. Bono. We're glad to have you here today. Next, I would like to introduce Dr. Gassim. Dr. Gassim is a South Sudanese medical professional with over 10 years experience in the non-profit private sector. He earned his master's degree in tropical medicine and infectious diseases from the Liverpool School of Tropical Medicine, and a postgraduate diploma in tropical medicine and hygiene from the London School of Hygiene and Tropical Medicine. He has a medical degree from the University of Juba and currently is the founder and CEO of Access for Humanity, a non-profit national non-governmental organization that provides health-related services in over 35 counties in South Sudan. He is also a PhD candidate at the University of Amsterdam in the Netherlands. Welcome, Dr. Gassim. Next, I would like to introduce Dr. Kandyang Modi, who is currently off the screen but will be joining us soon. Dr. Kandyang is a graduate of the University of Juba, where he attained his undergraduate degree in medicine and surgery in 2007. From 2008, he has worked in healthcare with a focus on women's health and reproductive health services and maternity services. From 2014, he also worked in the public health sector after obtaining his master's in public health from the Hebrew University of Jerusalem, Israel. Next, I would like to introduce Dr. Winston Nara, who is joining us from the diaspora. Dr. Winston is a medical doctor specializing in pulmonary and respiratory medicine. He trained in undergraduate at the University of Khartoum and did his internship at Omdurman Hospital. He then went for a fellowship at the University of Buffalo and did his residency at Mount Sinai Queen's Hospital. He's certified by the American Board of Internal Medicine, and he is also certified in pulmonary disease and sleep medicine. He is currently based in the US and works at the Center for Respiratory and Sleep Medicine in Noblesville, Indiana. Welcome, Dr. Winston. Dr. Justin, welcome. I'd like to introduce Dr. Justin, a fellow pediatrician. Dr. Justin Bruno is a pediatrician and a child health specialist. He attained his undergraduate degree in Mbarara University of Science and Technology in Uganda. He then trained in pediatrics and child health and got his Master of Medicine in Pediatrics at the Makerere University in Uganda and attained a PhD from the University of Bergen in Norway. He's currently an assistant professor of pediatrics and child health at the College of Medicine in the University of Juba, South Sudan, and is the executive director of Al Sabal Children's Hospital in Juba. Welcome, Dr. Justin.
Thank you.
We will go. Thank you, gentlemen, and welcome. Thank you for taking your time off your Sunday to be with us today, and we hope that this will be a very fruitful discussion. So we'll go straight ahead and start with the questions, and I will start with you, Dr. Bono. If you can please unmute yourself. Dr. Bono?
Yes.
Okay, the first question is for you, Dr. Bono. Welcome.
Thank you.
So, Dr. Bono, I'd like you to please describe for us what the health system structure or hierarchy of healthcare facilities in South Sudan is, and what healthcare services are provided at each level, what is currently available, and whether there are any referral systems present, and some of the challenges that are encountered in providing health services at state level. So, health system structure and hierarchy, what services are provided at each level, what is available and what is not, and if referral systems are present, and what the challenges are in providing health services at the state level. Dr. Bono, welcome.
Thank you. It is nice to give me this question, and I hope I will be able to satisfy by giving proper answers. At the state level, there is health system going on, which is implementation of the government policy which for the whole country. In the whole country, the health system is divided into parts. There is the primary health care, secondary health care, and tertiary health care. And all these are implemented at the level of the community. And actually, the way you put it is correct because the community, most of the community are in the states. In the state, there are activities of primary health care services, secondary health care services, and and tertiary health care services. But unfortunately, as you have said in your introduction, South Sudan has been in a war for a very long time. And during independence, uh, the government of the South Sudanese people inherited the health facilities or health system which was already down there during the war. But unfortunately, most of these health systems were destroyed. And then they have to start from zero. When we talk of primary health care is the frontline system. It is where you start with the patient at the state level. And the system is planned in such a way that they start with the simple issues, the moderate, severe cases, and cases with specialization. The primary health system is composed of BOMA or village health units. This is managed by BOMA health workers, which is a part of a system that we call the BOMA Health Initiative. In this system, people who are committed, at least primary school leavers, are selected as volunteers. They want to serve their people. They are the one to give health education to the community, the importance of health, because this is where our problem is. People cannot identify what is their problems and utilize it. So it is these people who are trained to do this job. And this is applicable in all states. Next, at that level, these people will be the one, for example, a woman is pregnant and she doesn't want to go, so it is unit where the case will be identified and they deliver the services that they can deliver at that level. Then the patient can be referred to the primary health center where certain level of services is also delivered by specific people. And then from there, it is referred to the county hospital. This is the policy. From the county hospital, it should go to the state hospital. And then from the state hospital, it goes to the referral or the national, we call it also teaching hospital, where you get different specialization. This is the system. But unfortunately, because of the difficulties people are facing, you don't get even this division of services in every state. Theoretically, they are there. In some states, you don't get them because either because there is no health facility, no structures, or there are no staff. If the staff are down there, the services are not down there. And especially the issue of the human resource. Human resource is really a problem. We have got inadequate human resource in number and in quality, not only number. Number is down there. Even those who are present, they don't have that quality to deliver the services that they are supposed to deliver. Somebody may be a nurse, but he has been a nurse for a long time because really the last graduates of nurses during Sudan was in 1990s. And there were some people who didn't graduate. These graduates, some of them have never attended any training. What do you expect from them if they are not trained? As regarding the referral system,
Dr. Bono, you're breaking a little there.
the referral from the primary health unit to the primary health center, depending on the situation and the condition. If it is a mild case, the primary health center is near and so on, people can just walk. But if it is far, it needs yes.
So, Dr. Bono, we'll get back to you in a bit. It seems you're
It
breaking
needs
up a little bit
a
there.
repair, which is sometimes not down there. But in some areas, yes, they are down there, especially the units or the health facilities which are support. Yes.
Okay, Dr. Bono, you're breaking a little bit. You're breaking up a little bit there. We'll come back to you. I think what I've gotten from you is you've actually laid down for us what the hierarchy is, and you have also told us that one of the major challenges is human resources, and the fact that the human resources that are actually there have not been also undergoing continuous training, and therefore they are stuck at the level they were when they graduated from their particular training. So we'll get back to that in a bit. You'll tell us more of the challenges. Let's go over to Dr. Justin. Dr. Justin, if you can unmute yourself. You are currently the executive director of Al Sabah Children's Hospital, and therefore you are the right person to talk to us about pediatric health services. So could you please tell us how many pediatric hospitals are there in South Sudan, and why is it important to have a facility that's dedicated to pediatrics only? What are some of the services that are provided at Al Sabah Hospital? What is not available? What is available? And what are some of the challenges you've encountered in providing pediatric services? And if you could just go into a few of the solutions for these challenges. Dr. Justin.
Thank you very much, Anne and the team on board. So far, I know Al Sabah is the only functional children's hospital in South Sudan. There used to be one attached to Malakal Hospital. I'm not sure if it is functional, but to my best of my knowledge, Al Sabah is the only one that is functioning at the moment. Why is it important to have the pediatric hospital on its own? Pediatric hospital on its own, it is the best to meet the need of children 24 hours almost every day. It is a setup that is basically contributing to meeting the needs of these children. That is why it needs to be set up separately, because children are special and they have a special need. It also contributes in essential way to primary health care and wellness of the community and the children themselves. So that is why it is essential, because it also promotes preventive services that in things that affect children and the community. Because pediatric doesn't deal only with children, deal with the family. So prevention and wellness of the family is key here. That is why the hospital is wholesome for the family. The services now available at Al Sabah include the following. We offer 24/7 emergency care, routine OPD care, outpatient care for those who may not understand. We also do inpatient care for those who need to be admitted. And we offer a few specialized services like neonatal care. We have a neonatal unit of its own that take care of the newborn. And we also take care of those who are within the first minutes of birth and were incorporated with the Juba Teaching Hospital to the maternity hospital, because that is where the ward is set for the newborn. And those others, after one day, they are admitted in Al Sabah directly. And we also offer services for severe acute malnutrition with medical complications. Those are specialized services. We offer services for TB in children. We offer services for HIV in children. And those are the things we do. We also do routine investigations in the lab, and we also do specialized care, investigation like hematology and chemistry investigation. In addition to that, we also offer preventive care like EPI, immunization of the common diseases in children. Those are what we offer. What don't we have in Al Sabah? The big gap is we don't have pediatric surgery in Al Sabah. It's mainly medical, and that is a big gap. So the children that get problem, we refer them to other hospitals, and they get mismanaged. And that is the direction we need to go to introduce pediatric care. Investigation-wise, we're lacking. We're sort of imagings, such as X-ray, ultrasound, CT scan, and MRI. We refer our children out to get those services, and they're damn expensive, and they cannot get. And sometimes they end up in queues. The other service that we don't have is we don't offer oncology services. Children with cancers, it is a nightmare. We keep referring them to the neighboring countries or to to Uganda or to Kenya or to Sudan for oncology care. We can diagnose here, but we cannot manage. We don't have the medication within the country. So those are the things that are challenging. Hematological care is also scanty. We have so many children with sickle cell. We do our best to take care of them, but when they needed advanced sickle cell care and others that are related to hematology, we cannot handle them in Al Sabah because they need special attention, and we don't have those services in full. They are like halfway. Challenges are so enormous. The challenges include human resource. From the consultant point of view, we are very few in the hospital, despite the volume of the hospital is high. And all the cadres in healthcare, nurses, medical officers, name them, they are few. The other hurdle that we have now, we're entering rainy season, is we don't have oxygen supply. We keep filling cylinders from the neighboring countries, and then at the end of the day, children suffer them. And if child come with severe severe pneumonia, sometimes it can become very difficult to handle when we run out of oxygen. We use oxygen concentrators, and that is linked to power. Most of the time, we have challenges with power in Juba. For those of you who have been in Juba, and that is a big challenge. Electricity is never reliable here. And so even if you have oxygen concentrator, when power goes off, there the life of the child hanging in balance. As I said, we don't have surgical unit here. And so this surgical wing is key to children. And it's a big challenge to us because we keep losing children as they are mismanaged in Nana Hospital because they don't understand the need of children, that children need to be given immediate care. Inadequate investigation that I've mentioned is a big challenge to us. And most of all, there's either poor pay or no pay for health workers. So most of us working here, we're basically like volunteers trying to do our best in this country of ours. What are the solutions? The solution include, like, one of the challenges, supplies, of course, of medication. The system we use in South Sudan here is a push system. This country is run by NGOs. The health sector is basically run by NGOs. The government has handed so over to the NGOs. And so the NGOs and the government use the push system. You know, we are special, we're children. And so when you just push anything to us, it doesn't meet our need. So they may need to be introduce a pull system where this will ask us, what do we need as children? And then we'll be able to tell them the list of what we needed as children. Because why do you bring for us tablets when we don't need them? And at the end of the day, we have nowhere to put them. And they just have to burn them at the end of the day. It's a waste of resources. We need an oxygen plan urgently. Otherwise, we keep losing children for no good reason. We need to increase in those investigations, like introduce an X-ray here, so that it is costly, is not costly to the children and their parents. We also need to improve infrastructure because at the moment we are meant for a hospital to supposed to be 100 beds, but we're over 200 beds, and the infrastructure is not enough. So those need to be introduced. The challenges are so many that I don't want to bore this forum with it. Most of you may know it. Thank you very much.
Thank you, Dr. Justin. I think from what you are describing, the situation sounds really, really terrible. If it's gotten to the point where even oxygen provision is a problem, and yet we know that pneumonia is one of the top killers of children, especially under 5. It's quite unfortunate that it's come to that. And I think our Ministry of Health has to take more responsibility for providing healthcare instead of really depending on NGOs completely, because at the end of the day, we will have to be able to run our healthcare system ourselves, and we should work towards doing that. And possibly even as doctors and people in the medical profession, it would be important for us to also provide some of those solutions if we can. So hopefully we are able to band together and be able to sort out some of those issues that are going on in the country. But mostly the biggest problem is a leadership problem, I would believe, and I hope that is worked on, and things actually get better in terms of healthcare in our country. So you've mentioned some of the things that we don't have in terms of provision of services, and talked about the lack of pediatric surgery. And I think Dr. Bono has also mentioned about human resources being an issue. So Dr. Justin, what are some of the commonest health issues that you find are affecting the pediatric population based on your experience in Al-Sabah, and what do you think is the reason for these conditions being more prevalent And what are some of the strategies that can be used to reduce some of these prevalent conditions in the pediatric population? Dr. Justin.
Yeah, thank you very much. The topmost four are these. Severe malaria is one of the top killers in this country for children under 5. And once it comes to peak season of rain, it will be a nightmare for us in the hospital because it is the most top one. The second one is pneumonia. And most of the time, those who get severe pneumonia, we're in big trouble as we don't have oxygen, we don't have sufficient antibiotics. That is a big challenge. Knowing our environment and our hygiene is not so good, gastroenteritis or acute water diarrhea is the next common one on the list. And then following that, we have severe acute malnutrition, basically with medical complications, but most of it are nutritional drive. The shortages of nutrition in the population, and so the children are badly hit because the adult will serve themselves first, and then the children ended up not getting whatever they need. Those are the topmost four. The others is related to that is we get children with burns, and that is why we need a surgical unit here. And then we get children with trauma. They get involved in accidents, and being managed in the adult unit on Juba Teaching Hospital can be a nightmare. So far, those are the few that I can list, but the topmost four rank high in the list at any time in South Sudan. Thank you.
We'll continue a little bit with you, Dr. Justin, since you will not be with us past the hour. So most children in sub-Saharan Africa die before their 5th birthday due to vaccine-preventable diseases. What vaccination services are currently available for the under 5 in South Sudan, and what are some of the challenges associated with providing vaccination for children in South Sudan? And maybe you can give us a few recommendations before we go to Dr. Gassim.
Thank you very much, Anne and the team. In South Sudan, we offer what is called, we have the EPI, which is expanded program of immunization, and we target the most killer diseases. And of course, we offer BCG to these children. We offer polio vaccine to these children. We give DPT, which is diphtheria, pertussis, and tetanus to these children. We give also HIP or hepatitis B and H influenza. We give them measles vaccines. Those are the vaccination services that are available in this country at the moment. What are the challenges associated with it is that the routine immunization is extremely very low. The reason data shows that the EPI department shows that the whole country is between 48 and 49%. And for good routine immunization, it's supposed to be 89 or 90 plus. And so you can see that our routine immunization is one of the lowest so far in the region. Number two of the challenges is that there's missed opportunities. Most health workers are busy with other things. They forget to, when the children get in touch with the hospital, they're supposed to check their cards, see if they're immunized, and immunize them. Those opportunities are missed. Randomly just asking mothers when they're leaving the hospitals, you find that they have not been asked about immunizations, let alone checking the cards. So those are missed opportunities that health workers are supposed to have done, and that is a big challenge that we can address. Now, related to our routine immunization, currently the country has an outbreak. We have an outbreak, a polio outbreak in the country, which is circulating vaccine-derived polio virus in the country. And some children have become paralyzed with that. At the moment, we have 54 cases in South Sudan of this virus that is circulating in the community. And this has affected the country. And it's not only one state. All the 10 states of South Sudan are affected with this virus at the moment. So we have a vaccine drive because we are using oral polio. So it ended up mutating and affecting our children. What are part of this solution? I think all of us need to do an increased routine immunization. All of us, especially the pediatrician and the health workers, need to get out and really promote in one way or another routine immunization, because it is a key to anything. Why that is those outbreaks are there? Because our routine immunization is very low. The other thing that we can solve is give awareness to the health workers how important immunization is, so that those opportunities of children coming to health centers, because there are many children that come in contact every day, but we miss asking them and we miss vaccinating them, and that is unfortunate. Regarding the outbreak, current solution being given to it is that we are doing responding to this outbreak, doing those mop-ups to give them additional vaccines in these states. And so there is SIA going on, supplementary immunization going on in the country, in different states. But along with it, we need to go and introduce the injectable polio vaccine, not the oral polio, so that will help the children. But this has also its own disadvantage, because it will only protect that child that get it, and there will be no herd immunity. Okay, WHO also and global partners are now pushing to introduce a modified version of oral polio vaccine type 2. It's called novel oral polio type vaccine, to counter that outbreak. So with this few, I think these are part of the solution that most of us are in our hands. We can do it. And this is easy to solve, because most of it doesn't need any money at the moment. Thank you.
Thank you, Dr. Justin. I like the fact that you have actually passed the baton to the healthcare workers to ensure that those opportunities are not missed and children actually get the vaccines because they're unavailable. Now, based on what you're saying about the outbreak of polio going on, I think this is a good way to get into the next part of our questions. And Dr. Gassim will be answering some of the questions on that. I know surveillance is an important part of detecting outbreaks, and infectious diseases are quite rampant in our country. And this has actually contributed to most of the morbidity and mortality in our country. So Dr. Gassim, the impact of research and the use of data to influence policy change has been seen in all sectors, including health. Is the same happening in the field of healthcare in South Sudan? And what are the strategies that are being used to ensure that this data is put to good use, or research in healthcare is encouraged? What are some of the challenges and possible solutions? Dr. Gassim? Okay, Dr. Gassim seems to have gone off the screen. Hopefully he'll come back, then we'll just go back to him. Dr. Gassim?
Okay, thank you, Anne, for the question. Actually, most of the health intervention and strategies to tackle diseases are made based on the guidelines in South Sudan. That is to say, existing WHO guidelines were adapted to the context of South Sudan. However, research are being conducted in South Sudan, but they are mainly done by either students as part of their requirements to fulfill their degrees, or by private institutions like NGOs as part of their grant or project requirements, and also by the Ministry of Health, also because of donor requirements. Often, most of these researches are often donor funded. I don't think our own driven research interventions were carried out in order to influence policy. Maybe I'm not aware of such studies, but I'm also not aware of anybody in the Ministry of Health or in any of our public universities that are tasked to ensure research conducted in the country.
Gassim seems to have challenges with connection. Can you maybe move to the next speaker?
Sorry?
Dr. Gassim, we can hear Dr. Gassim. I don't know if the rest of you can hear him.
No, I can't hear
Can you hear me now?
Dr. Gassim, go ahead.
Can I go ahead? Can you
Dr.
hear
Gassim
me
is
now?
muted. Maybe tell him to unmute him.
We can hear Dr. Gassim, Dr. Justin. So he should go ahead. Dr. Gassim, go ahead. We can hear you. Dr. Justin, I think the issue might be on your side because the rest can hear him. Go ahead, Dr. Gassim.
Okay.
Oh, okay. Okay. I was saying, I don't think our own driven research intervention were carried out in order to influence policy in the country. And I'm not sure or aware of anybody in the Ministry of Health or in our public universities that's attached to carry research conducted in the that these studies or research are being used to influence policy. Of course, there is the body, the Research and Ethics Department in the Ministry of Health, but I think they are only looking at the ethical part of the studies, either to approve or disapprove these studies, but they don't go further to ensure that studies which are conducted in the country are really used to influence policy or change policies in our health sector. I'm also not sure that the strategies that encourage researchers in healthcare exist in South Sudan. For example, for the last over 10 years, we have a guideline for the treatment of malaria with a specific anti-malarial medication. Yet, all over the country, we have almost all different types of anti-malarial medications that are being used, and there are several individual reported cases of unresponsiveness to treatment as a result of using some of these medicines. And until today, we never thought of testing this antimalarial medicine in order to pin down the best treatment options for our country. We don't even know the resistant pattern of malarial parasite strain that we have in our country. We don't know the types and the distribution of the different malarial parasite across the country. And this makes it difficult for us to understand what works best for the country. I would say the possible solution is to allocate financial resources and to dedicate national experts for research and evidence-based policy changes, because research has to be encouraged for better health outcome in the country. Back to you, Anne.
Thank you so much, Dr. Gassim. I think that also falls back on us a little bit as professionals in healthcare, that we too should actually be able to involve ourselves in research, but the system has to be in place to encourage that to happen. Because really, if we are still giving antimalarials that maybe the parasites are resistant to, then we have an issue there, because we will not be having any impact or dent on mortality or morbidity associated, especially with malaria. Dr. Justin has talked a bit about that being one of the most common infectious diseases affecting the children in South Sudan. Now, infectious diseases are rife in South Sudan, and Dr. Gassim, if you could just tell us which are some of the most common infectious diseases in the country, and whether women and children are disproportionately affected and why, and whether this epidemiology of these diseases has changed with the COVID-19 pandemic, and if it has, why, and what can be done to ensure that focus and services for the treatment and prevention of these diseases is not lost because of the current pandemic that we're facing. Dr. Gassim.
Yeah, it's easy without looking into any data to say that chest infection, malaria, gastrointestinal infection, skin infections, neglected tropical diseases, and outbreak diseases such as cholera, polio, and now COVID-19 are amongst the most common infectious diseases in South Sudan. Although we have data on the common diseases in South Sudan in the District Health Information System, however, we don't have a comprehensive summary to confidently say that we have this type of disease is more prevalent in this area compared to the other. This is because the data in the District Health Information System has some gaps, and no one is available to give us such information from the Ministry of Health. Some studies or research is done by the private institution and reported on some of these data, but we lack a comprehensive report. I would say it is all of us, the health professionals, to be blamed, including myself, because we may only need to do a desk-based kind of study to summarize all the available existing data that are collected through the DHI system, the District Health Information System, or through these multiple studies that were done by students, by NGOs, and by the Minister of Health into a one report that can be published and shared by the health policy or policymakers. Coming to women and child health, we have amongst the worst indicators in the continent and even globally. We all know that the status of women and child health actually determines the status of the health system of a country. Yet, South Sudan, we actually lag behind. For example, Currently in South Sudan, the infant mortality rate is at 63 per 1,000, the under 5 is at 96 per 1,000, and the maternal mortality rate is at 780 per 100,000. If we look into this data and we compare to 10 years ago, we can easily say that we have made major achievement or improvement in terms of maternal mortality rate, because around 10 years ago, it's around 2,054. Now it is 780, that's around 800, which is a big achievement. But then when you look at the infant and the child under 5 mortality rate, there's not much progress that we have made. But also these data are based from the WHO and the UNICEF. But I may question the accuracy of this data, because I'm sure women and children who are born or die in the most remotest villages in the country, they might have not been captured in this data. So maybe this data for the mortality could be higher than what is reported. And of course, COVID-19 has impact on the epidemiology of almost all diseases, especially since the beginning of the pandemic. For example, we have lost many lives to untreatable diseases like bacterial pneumonia, asthma, and many other chest diseases, which are treatable just because of stigma and fear, not only from the public but also from the health workers. Up to date, awareness campaigns are still needed to ensure the pandemic doesn't continue to negatively affect the focus of other diseases. Back to you, Anne.
Thank you for that, Dr. Gassim. I think basically what you've indicated is that we need a way to centralize this data and actually have a unit that's dedicated to collection of this data, and in such a way that it is accessible to anyone who would need to use it, either for a program development or for policy development. And this is a system that needs to be established in South Sudan. The skeleton is there, but we need to actually put it together so that there's actually a unit and a system in place that can centralize all the data available. Now, Dr. Justin had talked a little bit about an outbreak that is currently ongoing on polio and for polio, and what is the state of services for infectious disease control and emergency response, prevention and treatment in South Sudan, and what are some of the programs that you know that are targeting this infectious disease and their control, and specifically why are those diseases targeted and what impact have these programs had? So what is the state of services for infectious disease control and emergency response, prevention and treatment, and what are the programs that are targeting these diseases, and which diseases are targeted and why?
Yeah, infectious disease.
Some of the challenges also that are faced by these programs and some solutions.
Okay. Yeah, infectious disease control programs in South Sudan are often run as parallel programs and are often donor-driven. If we talk about emergency response, they are not designed to be continuous process with existing structures that, but rather they are based on outbreaks. For example, if there's an outbreak occurring anywhere in South Sudan, such as, for example, cholera or the current COVID-19 outbreak, then a response team or body or structure is developed, and often supported by WHO, UNICEF, or any of the international partners, headed by the Ministry of Health. Some of the programs in South Sudan targeting infectious disease, including the malaria control program, HIV/AIDS control program, tuberculosis control program, NTDs, and others. These diseases are targeted mainly because of donor interest. For example, let's say the Bill and Melinda Gates Foundation is interested in eradicating malaria and also polio globally. They invested a lot of money in such programs. And in the same way, like, for example, the Carter Center is interested in eradicating guinea worm, and so on. This is how some of these infectious disease programs are tackled in South Sudan. These programs have significantly, we can acknowledge that they significantly impact in tackling this specific disease over the years. However, there are challenges such as draining skilled personnel from other primary healthcare services, as these programs often pay better and therefore creating a kind of inequity of payment amongst health cadres, which may be equally qualified or equally experienced. Also, we have on the other side, sustainability of such programs will also be a challenge when the donor withdrew, because we expect the government or the Minister of Health to start taking over these projects and integrating them into the primary healthcare system, or at least from now they should take most of the responsibilities and funding for this project. And from the way I see, most of also these grants or the programs are managed by internationals at a higher level, but then we don't look into building the capacity of the local so that in the long run they can take over to implement such programs. Back to you.
Thank you, Dr. Gassim. I think that's a very good overview of what some of the challenges that are brought about by some of these programs, especially with the iniquity of pay when it comes to healthcare workers, and the fact that there's a drain in terms of human resources into the NGOs, and therefore the government-led facilities and the Ministry of Health-led facilities suffer because of that. So this takes us to our question for Dr. Winston. Dr. Winston, welcome and thank you for joining us from the diaspora. So one of the major issues that we know is associated with healthcare provision is healthcare financing. And if you can tell us from other countries or from the diaspora, what strategies have been shown to work when it comes to healthcare financing, and how can this be applied to South Sudan? And further on, if you can also talk a little bit about the strategies that have worked in the diaspora for developing human resource for health, which is something that all our speakers have indicated is an issue, and what has worked in the development of human resource for health, and what are these strategies that can be applied in South Sudan, and if there is a role for task shifting in South Sudan. So financing, healthcare financing, and development of human resource for health. Dr. Winston.
Thanks for having me today. I'm honored to be among these esteemed professionals in my mother country. In the US, the system has been built over decades and maybe even centuries. In the 1800s, the healthcare used to be fee-based. Practically, what it used to be is a physician would go door to door and then get paid for their services. And over the turn of the century, around 1900, things has become so expensive that there was the Industrial Revolution. So there was a lot of people who were working, but they were working minimum wage. That means they did not have enough means to have this private doctor come up to them. So that's when they started to develop private insurance. The first one was called Blue Shield and Blue Cross, started around 1920 or 1918. And basically it was a group of doctors who said, we're going to go to this school board. And they have as members of the school board, most of them are teachers and their family members. So those people formed an organization whereby they'll put all their money and resources on a monthly basis into that fund. And when one of the members of that fund becomes sick, they go to the doctor, and the doctor provides services, and the service is being provided is paid for by the funds from that health insurance, if you would say. To be able to fund healthcare in an emergency basis, you have to have a pool of funds somewhere. And the only way to do that is for everybody to chip in. In Southern Sudan, for example, I would presume that every single ministry or every single organization should have a way of subscribing into a pool of funds, which will be the national healthcare, and that can be based on taxes. So if somebody is getting paid a certain amount, they are taxed to a certain degree, and that money goes to the common fund, which will be there available for them. So the rationale is not only to uh, pay for your services when you're sick, but you also have to make sure that you have enough funds for when you get older, you get retired. That fund is available for you to help you. So it behooves for us, the young people, to be able to pay for the people who are retired now to get the services. So that's number one. Number two is obviously to uh, have a government itself that can allocate funds. For example, in 2018, I think the GDP of Southern Sudan was 20 billion, and that's for a population of about 10 million, 11 million. So give and take, that's a lot of money for every single individual if that money could be correctly channeled. However, that was not possible. In the US, for example, a per capita expenditure for for one person is about $10,000 or $11,000 a year for a single person. In South Sudan, it's about $22 per annum for one single individual. But if you look at the resources that we have, our GDP, and if you can divide that up, if we should have at least $2,000 spent on every single individual in Southern Sudan. But that's not possible because of the challenges that we have. What we have is a problem of infrastructure in Southern Sudan. Without an infrastructure, you cannot deliver services. That's number one. Number two is also security. So the government in Southern Sudan is focused on security, which takes all its money. And therefore, there's nothing left to be spent in healthcare. That's number two. And number three, also, people who are elites in Southern Sudan, they don't care because they can always go abroad to get treatment. If I heard correctly, in the past, there were people who went to India or UK or wherever with about $100,000 for a single individual to be treated. And that money could be spent on millions in Southern Sudan if people had the will, or at least if they care for their country. But that's not what I see in Southern Sudan. Obviously, we all talked about the preventable diseases, but the most important thing is to fund the healthcare system, is to fund preventive care. If we don't have the sanitation, all these preventable diseases will continue. We don't have the sanitation. That's number one. Number two, we don't have a good water system, sewage system. We don't have those. You're going to have this diarrheal illnesses because of poor, delivery of water and removal of waste. That's going to be a big issue in South Sudan, and it continues to be, unfortunately. I think the easiest way to do is to probably mandate that everybody should have a way of getting rid of their waste in their homes or in a dedicated place where we can prevent or at least accumulate all the waste product in one place so we don't spread it around. So that's the way to fund healthcare, is also to fund the preventive healthcare system.
Thank you,
Prevention
Dr.
also,
Winston. Thank you, Dr. Winston. I'll get back to you in a minute. You will continue to just give us an overview about how to fund the preventative services, and I can understand where you're coming from, in the sense that by the time we're thinking about healthcare financing, the question is there infrastructure? Is there clean water provision? Are we able to treat or prevent the most basic illnesses that may become due to sanitation and hygiene. So I'll get back to you in a minute because Dr. Gassim and Dr. Justin will be leaving in a bit. So Dr. Gassim, if you can just give us a conclusion and some recommendations and maybe just say a few things about access to humanity. Thereafter, then Dr. Justin can give his conclusions and possible recommendations in view of pediatric health services. Then we can get back to you, Dr. Winston. Dr. Gassim, 2 minutes, then Dr. Justin, so that you can leave. Thank you. Dr. Gassim? I think Dr. Gassim is not. Dr. Gassim, your conclusion, recommendations before you go? Okay, Dr. Gassim doesn't
seem to be. Is it me or Dr. Blue?
Yes, it's you then, Dr. Justin.
Okay, thank you. And I'm really happy to be part of this meeting. I could have stayed longer, but I have to join another meeting at 5 p.m. That is around 2 minutes from now. What I would say a lot of funds have been invested in this and are being still now invested for the healthcare system in South Sudan. But what we need to do is to appropriately allocate and utilize this funding. It is more than enough to put our health system on track and to solve most of our health issues, including research. I would also say that we as health professionals, whether in diaspora within the country, we need to put all our expertise in place, whether from remotely or physically around here in South Sudan, so that we'll be able to fix the issues of our health system, starting with research and looking into all the data that we have currently, so that we can be able to understand what are the actual gaps and how we can address it, and what is the most innovative, cheap way of doing.
Sorry, I think we lost Dr. Gassim there. He was just giving his recommendations and emphasizing on the need for research and the fact that we actually have some of the finances available. Dr. Gassim, 1 minute before you disappear, then Dr. Justin can come on. Dr. Gassim. Go ahead, Dr. Gassim.
Yeah, sorry, my internet got interrupted. Yeah, I was saying we need to put more effort into looking into our existing data and try to understand what are the gaps and how we can address it. And I think both of us who are within the country and those who are outside the country, we can do that. We just need to allocate our time and to put all the resources available in order to make our health system work. And with this, I think I'll get back to you guys. Thank you for the time.
Thank you so much, Dr. Gassim, for joining us. We wish we could have stayed a bit longer, but thank you so much even for that conclusion and the recommendations that we're giving. All the best in everything that you're doing with access to humanity. Dr. Justin, you can go ahead and also give your conclusions stroke recommendations. Thank you.
Thank you, Dr. Ann, for having me and the team. I'm sorry I have to leave early. I have another engagement in a few minutes. As I've elaborated before, in the pediatric care, there's a lot of challenges. And one of the questions that I did not ask, maybe I'll need to give you the answer before I go, is at the moment, there are 11 pediatricians in the country out of over 30 or 40 that are trained. Where are the others? They're still outside the country. Those 11, where are they? There are only 4 in Al Sabah, which is the only children's hospital in the country. And then where are the others? 5 are working for international NGOs in Yambio, Nimule, Maban, Kwajok. That is what is happening. 1 is in the University of Juba, and 1 is in private practice. That makes the 11 who are in the country. So at the moment, there are only 4 in Al Sabah, and that is a huge challenge. What are the recommendations that we need to go forward to? We need to have an improving health system, and we need to own our own health system rather than giving it to the NGOs. That is a big disaster for us, having the NGOs run our show. The other second recommendation that we need to improve on health financing in the country. There's no health for free. For goodness sake, you give less than 1% for health. What do you expect? And why do you blame the health workers then? And because that is what we're getting in. And then the other third recommendation, we need to improve the infrastructure. Even the only children's hospital that they have, if you come here and compare with what you have in other countries, you'll feel very sorry. But we have no choice. We have to work for our children and our people. That's why we're here. Data is lacking. We are not data on our own. We are just getting estimates from WHO, from UNICEF. We need to enter into research field so that we drive our health system using our own data. And that is the way to go. Having said that, what will be the conclusion? The conclusion I will encourage our colleagues who can afford to come to the country and contribute in one way or another. If you cannot come physically, contribute in kind to the children of South Sudan. You can do something even wherever you are. And then for the government, I think universal health coverage is the way to go for the children in this country if we have to save the nation. Otherwise, we'll disappear from this planet. And then what do we do for the children? Because the children, if we don't nurture them well, this country will have no people, because this is the future. And if we want to leave South Sudan behind to be a better country, we need to invest in children. Thank you very much for inviting me and having me on board today. And God bless you all.
Thank you, Dr. Justin, for that. We are glad you were here to speak for the children. And thank you for the good work you're doing in Al Sabah. And we are definitely going to look into how we can help for those of us in the diaspora. And if possible, even come back to South Sudan and contribute to healthcare provision in our country. Dr. Winston will go into some of that, how we can actually make use of the diaspora later on. But thank you so much, Dr. Justin. We appreciate your time and your dedication and service to our people. Thank you.
Thank you. Continue with the fruitful discussion. God bless you all.
You too, Dr. Justin. Thank you. So as Dr. Justin leaves, Dr. Winston, you were talking a little bit about how health financing would work, yes, but we need to also invest in preventative services. If you could please continue with that part of the discussion. Sorry for the interruption.
I'm glad to be back. Well, for the preventive service to be effective, it has to be cheap and available for everybody. And the way to start with that is obviously nutrition is number one. You have to feed people to prevent diseases. Mm-hmm. And you have to make sure that you feed them the right food. I think our staples back home, the food what we eat, if we just stick to it, we prevent heart disease, we prevent diabetes, we prevent other issues if it's available for us. But unfortunately, that's not available because obviously people just go hungry, people that have no jobs. That's number one. And number two is, mothers have to be cared for. Prenatal care is very important. If we don't invest in prenatal care, you would have a high morbidity and mortality rate on mothers as well as their children. So you have to invest in these two places. Some of the preventable diseases that our colleagues have talked about, like for example, malaria, we can invest in taking care of our backyard, our water system, stagnant water, and just get mosquito nests. However, people are focused on different priorities, and that's why we do not have those. These are very, very cheap things to be able to afford. In regards to funding, I talked about insurance earlier. Then in the US, there's the healthcare, the national healthcare is funded by what's called a Medicare and Medicaid. And Medicare is a tax-based system whereby all people who are at the age of employment, they're employed, they get taxed, and the money goes to that pool. So when they get older, there's money for them to use. Medicare is spent on people who are above 65 years or older. And also people who are disabled, who have chronic diseases that they cannot work. This money is spent on them. So you have to have this money available. If you don't have that fund, it's going to be difficult for the doctors to stay in the country because they cannot get paid. And these doctors get paid based on what's available that has been set aside. And of course, the where the doctors are paid in this country is when you provide service, you charge for it, and you don't get everything. It has to be analyzed. Do you deserve all the pay that you're asking for before you get paid? If you don't have those basic check uh, points, then you may be overutilizing your funds. You'll be spending too quickly. So there has to be also a means of accountability, not only just to bring the money in, but how it's spent and who is in charge of looking into how it's spent. For us, for example, if I overcharge the government or even the private insurance, at some point they will audit my data and I have to pay that money back with a fine. So that money will be available for the next patient who is sick for them to be able to care for. And everybody has talked about investing in studies. Um, it's very expensive to invest in a comprehensive study because not only will you take the data, but you have to make sure there's safety points all along the study before you conclude the study and make recommendations. I think for us in Southern Sudan, as everybody else has said, we are able to do retrospective studies because we don't have the means to put the funds forward, but you can go and review data that has been there. And I'm sure there's a lot of data that can be analyzed. We can do a meta-analysis to see exactly what are the conclusions from all these studies. I don't think we just need to study for the sake of studies. As Dr. Gussin said earlier, there's information, but are we using the policies? Are we implementing those? And what are the issues that prevent us from doing those? Do we believe in the data that we collected? You have to believe in that data to make sure you implement it. And people who are managing those healthcare policies, they have to believe in it and to look at the big picture as those policies are being for the population, not for individuals. As long as we are focused on individuals, we'll have issue with preventive care and the healthcare system as is general in South Sudan. The other way to fund healthcare here is, despite these two systems, the private insurance and the government funded, there are people who are not employed. And in this country now, people who are not employed or who are underemployed, there's what's called a healthcare market. In the healthcare market, different organizations, different health insurance companies have a smaller program where they can provide basic services, physical annual examination, basic medications, but not complicated services to be available. And those services are cheaper. People can go and buy, just like you're buying, you know, uh, a subscription to your phone system. You can buy into that market, pay a certain fee. So when you get sick, you go to the emergency room, you have that fee that is going to pay for your care. So this is also a way of subsidizing the system with a relatively speaking cheaper way. I have looked into Rwanda, for example. Rwanda have, I think they call it Motuli, something like that. Motuli Sans is whereby every different um, counties, bomas, Hilla, for example, people in that county, they talk to their elders and they all come up with a pool of money. So every single sector, every single boma has its own pool of money that's managed amongst themselves. It's not, it's not to provide service for somebody from other bomas, but from that people, from that county, from that village, they all provide funds, and that fund is available for when somebody gets sick. So I think that's something that we as South Sudanese, through our chiefs, we can do those. If we just have the interest that I'm paying for this today, I'm not going to get it today but I'm going to pay for it so that if my brother, my neighbor gets sick, there's going to be something for them to be able to be cared for. If we don't do that, and we only rely on the government will A, mismanage, and B, will not have enough funds. So I think some of it we have to take ownership of our own healthcare to be able to know it's important to fund it so it's there available for us. And I don't blame the doctors for trying to leave the country because they all have families, they have debts, they have invested so long and so much energy to be able to have a good living standards for their families. For us in diaspora, we have the expertise, but we as many people who went back, sometimes we go back and we feel that the government feels that as though we're coming to take over jobs that are available, although we're trying to come and help. So to be able to attract the diaspora professionals, first you have to make sure that they're safe. Security is number one. And number two, there have to be some sort of incentive for them to come back. In different places to initiate a healthcare facility, the government in that area gives you a tax break, whereby they don't tax you that high because you come and invest in that area, and then you're creating jobs for the healthcare professionals. You have to have some tax breaks. You have to have some security for people to come back. We all want to come back. Nobody wants to live in diaspora. We're sick of it. We don't have the family interactions. You're all within your walls, but yet we have kids that we have to raise. We have family that we have to raise. If we go back, we need to be able to say, you know what, I came and I'm honored to be back, and my life is not being threatened, and my well-being is not being threatened, and I'm giving my knowledge is being appreciated. You have to have somebody to appreciate what you're coming to bring back home. But if you're not appreciated, it's going to be difficult. One thing that Dr. Gassim talked about is the NGOs. The NGOs is people's money. You have to know that it's people in the US who pay tax, and this tax is paid for NGOs, and the NGOs is supposed to be non-for-profit. So our taxes is being used to fund those NGOs. Any NGO will have the interest of its parent country. It doesn't matter if they come to help you out, there's something that they're getting in return. If it's the notoriety, if they to get more money from you, if they're trying even to conduct a study on you without you knowing. There's some studies that are being conducted in African countries, for God's sake. People do not know that they're being studied, and for a drug that is to be used somewhere else. Some of the HIV medications that have been studied in Africa, Africans cannot afford. And these are studies that have been conducted in Africa with big pharmaceutical companies, and that cannot, and the medication is not available for Africans to use. So you have to, A, have the funds, and B, when you interact with the foreigners, you have to make sure that you know that you're better than them. They're not better than you. They just have the means, they have the funds, and that's why they come into your country. I think these are the main things that I think would probably help us in the future.
Thank you, Dr. Winston. I think you've also just mentioned a few things about how we can actually attract the healthcare resource that we have in the diaspora to come back, in the sense of providing them safety, ensuring that they get pay that enables them to feed their families and take care of their basic needs. And that is a problem that has actually been identified by all the speakers that we have talked to today. I'll come back to you, and maybe you can give us a few pointers on how we can develop human resource for health, some of the solutions that can be can lead to development of human resources for health, and how we can motivate our human resources for health further. So I'll go to Dr. Kandiang. Dr. Kandiang, thank you. Sorry, it's taken a bit long to get back to you. You'll be talking mostly about women's health, and Dr. Bono will also talk a bit about some of the issues also affecting women's health. So the question for you are, what are some of the commonest issues that are affecting women's health in South Sudan, and what are some of the reasons for this, and are there any possible solutions? And if you can give us a few words on GBV, and whether it's something that you have come across in your practice, and if there are any statistics in South Sudan, and whether there are services available for this, and some of the challenges in providing these services. Dr. Kandiang, the commonest issues affecting women's health, and GBV, the services provided, and the issues challenges and possible solutions before we go back to Dr. Bono.
Hello, I hope you hear me.
Yes, we do.
Yes, we do. Yes, we do,
Okay,
Dr.
thank you very much. Yeah, thank you very much. And I'm very happy to be part of this discussion today. And to start away, really, the issues affecting women's health in South Sudan can be considered of a wide range that can be from the issues of culture and traditional practices that most times block women from their human rights and exercising to choose health choices. One of them is also the low literacy or low education levels among our women. As we know, majority of South Sudanese um, population live in the rural, and therefore their education is expected to be a little bit low, and they cannot be able to read and comprehend, and they cannot be able to really be health literate. Now, there are also things to do with the low nutrition or poor nutrition, as some of our colleagues have mentioned, which can lead into generally poor health, particularly in the rural areas. And sadly, as we said already, majority of South Sudan is rural setting. The other thing is lack of understanding of the concept of safe motherhood, and that is particularly when it comes to the reproductive health. And this is wasn't really by the fact that this country is a male chauvinism society where men think women are only to get pregnant and have for them children as many as they wish to have. Now, what are the reasons for this? Include the fact that these issues are mostly on individual levels and could be expected that the best solution are to be found in what this forum is today doing, like to provide awareness raising to our populations, to our women, and also to educate our rural communities so that they can be able to know that their health is paramount and their health is really dependent on them. As somebody has said, health is an individual task that each and every one of us has to take good care of our health even before we look or seek any help from a medical practitioner. You asked about GBV, and what I know is that GBV can be considered as common, and what is necessary is that we don't have enough information or any national report on GBV as of now that I can recall of. This can be a little bit tricky because most of the reports on GBV are really from our implementing partners or development partners in the country that are mostly implementing services on health in different parts of the country. However, what is very important and more serious to remember in my experience when I worked in Juba Teaching Hospital in 2017 was to see that GBV is even affecting us young children as 3, because I had to work on a child of 3 years that was defiled by her old relative. So these are some of the sad things to remember about when we talk of GBV. Now, of course, at the moment, the situation has become a little bit worse as we hear reports from the fact that there has been COVID in the country and lockdowns. These issues had led into increase on GBV cases in the country. Now, of course, as mentioned earlier, the statistics on GBV is not easy to refer to at the moment because we don't have a proper study or survey to document particularly how many women are really, or men, because GBV is not only for women, are experiencing GBV and survivors. Now, some of the things that are happening or the services that are happening is that people who are able to report a case of GBV would be referred for care and at specific health facilities, and the survivors could get counseling and what we call as post-exposure prophylaxis for cases of HIV infection prevention. And also the services available are in Juba Teaching Hospital and two other facilities of the South Sudan Reproductive Health Association clinics, which is more to do with private practice. Now, the Juba Teaching Hospital is supported through UNFPA and provide those services through throughout the day and throughout the week. Now, we are here able to see that some of the colleagues and some of the challenges and possible solutions to this would be things like um, of course, challenges include stigma, which is really a fear of reporting about what has happened. And of course, the previous cultural issues and traditions where the parents of the girl would be thinking that it's better to keep quiet and not to expose their daughter as having had sexual harassment or GBV incident, and they don't get to report this to the police, and therefore there would be lack of data about them happening. The other thing is also that sometimes our law enforcement agencies would be like causing trauma to those people by maybe asking them a lot of questions, and then the issue here is mainly the fact that before you get treatment in the health facility, you need to get a police report or a police document to show what has happened to you. So this can make these young people or young women get away from getting services because they do not want to go to the police and then get those documentations and get those questions before they get a services. Therefore, what would be good is really to improvise laws for good punishment of those who perpetuate GBV for both men and women, because as we know, GBV is not only about women or about men. Both can be able to cause GBV. So I think this is briefly for what you have asked as of now. Back to you, Anne.
Thank you so much, Dr. Kandiang, for that overview and for indicating for us some of the issues that have actually facilitated GBV in our society. And we hope that some of the solutions that you have mentioned here will be taken up by the people listening in who make the decisions at the level of the Ministry of Health. So I'll go back to you, Dr. Bono. Sorry, it's taken a bit of time to get back to you. As someone who's worked at the state level and who has a lot of experience in obstetrics and gynecology, could you just give us an overview of what the components of maternal health services are and whether they're currently available at the state level and why they're important? And then maybe talk to us a little bit about some of the gynecological issues that you have encountered in your practice and whether services are available for this and what the challenges are with provision or access at state level and some solutions. So components of maternal health services, if they're currently available at the state, and what gynecological issues you've encountered, whether services are available for those, and what are the challenges with access at state level, and how can this be, how can solutions be found for this? Dr. Bono. Dr. Bono, if you can hear me, you're on mute. Can you go ahead, Dr. Bono?
Yeah, thank you. Yeah, the components of maternal services can be divided into parts. The services which are supposed to be delivered before marriage and before conception. There are services to be delivered during conception. Services to be delivered when one is in labor and then after delivery. But for the first part on there, preconception, usually only after they get pregnant. the reproductive health according to the policy of the country. If this policy is applied correctly, women can have very good health services. The first part is supposed to be with the adolescents. The policy is down there, but it's no implementation. And that's why we are having this issue of JBV, gender-based violence. It is during these people, this active group, these people who are sexually active, if they are taught their reproductive health, they will know what to do. But unfortunately, talking about reproductive health or sexual education is a taboo. And it is, I think the communities are supposed to find a way how we can convince, because most of the things happening are due to ignorance. Whatsoever you take, whatsoever complication you get in obstetrics, because obstetrics is the basis of life. Women are the basis of life. And it is said that women, we overlook them since we are the administrators. We don't pay proper attention to them. We are supposed to pay attention to them, because if they are healthy, the whole community will be healthy. If the mother is healthy and very good, she takes care of her children, she will not bring a person who is going to be violent. That's why we need to think about this. Yes, it is being introduced, especially among those people who are well-oriented, the educated people, people living in town. Some of them, they do come. And I want to mention is that when we talk of education, we don't talk about knowing how to read and write. It's not all. But education is to know how to live a healthy life. What do you need to know so that you are a good person in the community? What do you need to know so that you are a good wife or a good husband? What do you need to know so that you can be a good father for children? And at the end of the day, you will become a good citizen and then will be a good leader. But this is not down there, especially nowadays. Because the JBV that the doctor just talked about, you find that it is the learned people who do it. Those who do it, you find that they are graduates of senior secondary school. They have finished their senior secondary school education. Who knows, some of them may be to a university. If we come to the issue of don't give job to somebody because, I mean, on condition that he should satisfy your demands, who are the one employing people? Are the university graduates? They are the one. So for me, he who does is not educated. Knows how to read and write without knowing how to live a healthy life and to be a good. Let us come to the conception period, which is the antenatal care. All the services for antenatal care are down there, or they sit to the planning there, according to the strategic plan of the Ministry of Health. But the problem is the tools which are needed are not down there, which may be the infrastructure, the facility. You find a woman is living somewhere, and the nearest health facility you can go to is about 20 or 30 kilometers away from her. How is she going to go? Especially if you or it is down there near her. She is not aware that she can get services in the hospital. That's why we need health education to tell these people that please, that building you are seeing down there is to deliver this type of services, and these services are down there. Go down there, you will get somebody. That's why, according to the Ministry of Health, there is this policy of the Boma Health Initiative, where there are Boma health workers. These Boma health workers are people within the community, leaders, community leaders, that it is a person within the community, he is at least somebody of primary school living education, and he is resident here, and he is willing to serve people. His character must be known. This is the characteristic of selecting a Boma health worker. This person is going to be in the village. His duty is to see who who are the young couples here? He needs to talk to them. Please, you go. Now you are young people. You should do this. Why don't you go to the hospital to check the doctor before your wife gets pregnant so that you can know what to do? Or why have you said for a long time your wife is not pregnant? You need to go down there for consultation. This is the type of services that these people, the Boma health workers, are supposed to do. If there is a child having diarrhea, they need to know there are people. If there is a child having diarrhea within the community, it is he to teach them what to do. Give them ORS. Let them breastfeed. Let them be breastfed. And if it is continuing, then they have to go to the hospital, to the primary health unit, and so on and so on. A woman who is pregnant, not going to antenatal care, it is his duty. A young man somewhere having HIV, he is not taking his treatment. It is his duty to make sure that this guy is taking his treatment because he's important to the community. His death will be a miserable issue. He lives, he can be productive to the community. This is the meaning of the Boma Health Initiative workers, why they are down there. So when they come to the primary health unit, then they will get the services down there. What can be treated at that level is treated. What cannot be treated at that level, it has to go to the primary health center. And from the primary health center to the county hospital. From the county hospital, they go to the referral hospital or the teaching or national or referral hospital, which is actually the tertiary level of health services. But unfortunately, these facilities are not found everywhere. And if they are found, they are not well equipped. If they are equipped, the people to run them are not down there. Okay. If they are there, the medical supply is not supplied regularly, not mentioning the other consumable commodities that we need.
Sorry, we've lost Dr. Bono there. When he comes back, he'll talk a bit about medical supplies and what can be done and what are some of the challenges that are associated with the provision of medical supplies and equipment in South Sudan, especially at state level. We'll let Dr. Winston come back on because he'll be leaving in a few minutes. So, Dr. Winston, maybe you can answer your last two questions before you finish with your recommendations. The health system in South Sudan, we know, has to be built from the ground up. And what do you think some of the issues, what are some of the issues that must be prioritized in South Sudan, especially in healthcare, to support provision of basic health services to the population? And now that South Sudan is currently heavily dependent on donor aid, I think a few of our other colleagues have mentioned, what are some of the possible strategies that may ensure a smooth transition into the Ministry of Health establishing and taking up its role in provision of healthcare in the country? So what are the issues that should be prioritized in healthcare in South Sudan, and how do we transition from NGO-based and NGO-led healthcare into the Ministry of Health taking over? And give us some of your recommendations before you leave.
Again, thanks for having me back. These are two loaded questions, and a lot of us have already spoken about. It's just a matter of how to try to bring it back to focus. Obviously, number one, Dr. Bona has talked about the Boma initiative, and because that's what the problem we have is access to healthcare. We don't have access to healthcare in the villages. So the Boma initiative is some solution that's already there. It just needs to be implemented and followed. So that's number one. The challenge that we have is obviously communicable diseases, mental health, violence, early mortality. The lifespan for an adult in Sudan South Sudan is about 55 years old. In the US, it's about 78 to 80 years old. So that's a big gap. And that all leads to the disease that we die from, most of it are infectious, which can be prevented by just good hygiene. That's number one. So access to Boma initiative and good hygiene will be the first priority to be implemented. Number two, In regards to shifting from NGOs uh, to the national, we have a lot of talented people all over the world. What I would suggest for the government, or whoever is listening, is to reach out to all the embassies and the embassies in every different country to try and reach out, disseminate information that we need all the talents that's available out there. You South Sudanese doctors who are there, please register with us, sign up with us. There's a need back home, and this needs to be only covered by people who are from that country, because anybody else who comes as a guest, they have their own interest. They want to take your resources and take it out. But if you have people from your place that you attract back home, they will invest all their hopes, their resources, their talents in those communities. So that's something that has to be, the embassy has to reach out to all the talented healthcare providers. That's in terms of bringing the providers back. And also, as we as diaspora, we can communicate, we can connect the institutions back home with institutions in the foreign countries. I have I instruct doctors in Indiana University that I can connect that university to some of the universities back home, and that has to be encouraged. The only way you could do that is for talented foreigners to be able to go there first, and this will be our liaison, our ambassadors to connect these two institutions, because they have to believe that when they go there to help, and they are secured to be able to come back to their families. In terms of information, I think information is key to how to improve our health infrastructure. But the information is so widely available now. It's widely available. We just have to have access to better internet connection. We can give lectures from overseas. If we can even do just recorded lectures. We can do those and be able to communicate. And even workshops, some of the workshops that can be done hands-on, you can see it on the video and you can implement it back home. So I think that these are things that can be done in a cheap way to be able to improve the healthcare personnel in South Sudan. In regards to the again shifting from the NGOs, like I said earlier, you have to make sure that you offer those people who are going back home at least tax incentive, meaning that they come there, they invest, you don't tax them high, so they can be able to invest more money and build up the infrastructure and also provide employment. If we don't do that, nobody's going to go back home to take that risk. Um, and last but not least, we as providers back home and here in diaspora, we just have to communicate. So this kind of forums, if you keep it lively all the time, it will connect us together. For example, I wish to go back home to help out, but if you and I and Dr. Kanjiang, Dr. Bon are here, we can talk about how can we build our own facilities back home with all different talents. We can build those facilities. You are there to help us as we come into the country to know this is the challenge and this is how things can be done. We can buy CAT scans, as you know, in the diaspora, we can buy a CAT scan. But how is that going to be used in Southern Sudan? Do we have the facility? Do we have the way to repair those scans? That's number one. Number two, I'm sure there's also radiologists all over the world who can read scans. There's Southern Sudanese radiologists who can read the scans. If you can do a scan in Yambio, somebody in the US can read it to you and tell you what needs to be done. But you have to have the personnel to be able to implement the recommendations. If you don't have those, it's difficult. We'll stay disconnected. Overall, we have taken the first step, and I think that's a great step to take. Um, if we just keep in contact with each other, that's number one solution, and everything else will follow. I don't think there's going to be one solution in one day, but it's just a matter of communicating and talking amongst ourselves so we can come up with a solution that A will help our people and B will improve the um, living standard as well as the mortality rate in our country. Um, to me personally, I have learned a lot from you guys today as to what's the challenges that are going down in South Sudan. In the US, we have different challenges. It's not those infectious diseases. We have challenges in the US about drug use. People die from using drugs because here people have so much to eat that they don't feel hungry, so they'll go and do stupid stuff. But we don't do that South Sudan. We're just trying to survive. We're just trying to get the basics. So we have different challenges, and I have learned from you guys a lot. And I really thank you for being there and coming up with this forum. And I will be glad to participate in the future. If I had enough time, I would stay longer, but I have another engagement. So invest in ourselves to take over from the NGOs. You have to have the money to invest and to come up with a healthcare insurance. We as community will have to pull together funds into different places, different neighborhoods that can be used for that neighborhood. As far as manpower development, communication, internet access, remote teaching, and marry our institutions back home with the diaspora institutions. And the embassies have to disseminate information that this is the urgent need in South Sudan is healthcare. And all you South Sudanese doctors, please come and sign up in those embassies. So we know at least who is who and what the needs are. And then we can channel those expertise in different communities and different aspects of healthcare. I, I take my hat off to you guys, and you guys are taking the heavy lifting back home, and I'm honored to be amongst you. And hopefully we'll uh, keep communicating. And I can't wait to go back and see my uncle, Dr. Bono. Thank you.
Thank you.
Thanks, everybody.
Thank you so much, Dr. Winston, for taking the time, and thank you for some of the information that you've given us and some of the suggestions that you've made. I think you have emphasized on the importance of the diaspora and the importance of collaborating with institutions in the diaspora and taking advantage of the human resource that we have out there for health and for other sectors. And I think that is something that we need to look into, because South Sudan is unique in the sense that we have so many people from all over the world who've been trained in various specialities, and we can use that human resource for health. So thank you so much, Dr. Winston. We look forward to having you in South Sudan to disseminate the knowledge that and skills you've acquired out there. Thank you so much for joining us, and all the best.
I will be happy. And thanks again for having me. Thanks so much.
Thank you. Thank you. Thank you, Dr. Winston. So, Dr.
I'm sorry,
Winston,
I'm sorry I look so old and a lot older than Dr. Kandi Young. Maybe not as old as Dr. Bono.
that's okay, Dr. Winston. Thank you so much. Thank you
It's
so
been a
much.
long time.
Bye.
Thank you. Bye.
Okay. So, Dr. Bono, we'll go back to you. You were giving a brief overview of some of the maternal health services that are available. If you could continue with that. And then you had also mentioned a little bit about equipment and essential drugs. And what we need to know now is whether there is also regular provision of equipment and essential drugs, and whether they're available within the state hospitals, and what are some of the challenges associated with procuring these essential drugs and equipment. Dr. Bono, before we go to Dr. Kandia. Dr. Bono, you're on mute.
No.
Go ahead, Dr. Bono.
Can you hear me down there now?
Yes, we can hear you. Go ahead, Dr.
Hello?
Bono. We can hear you. We can hear you, Dr. Bono. Go
Okay.
ahead.
Yeah. Okay, thank you. Regarding equipment, the equipments are supposed to be supplied by the central medical stores. Uh, but it is not that easy. They supply regular because they don't have a fixed time. It is according to the demand of the hospital or the facility. You if they are there, they give you. If they are not down there, you don't receive them. One day people get them, facility do get them from organizations. That means it is those health facilities, because not all the health facilities in a county, for example, are supported by the partners, by the NGOs. The NGOs will select some from facility. For example, in a county, they may take 4 primary healthcare centers and then 6 primary healthcare units. These are the ones that they will be supplying with equipment and emergency or basic drugs. But the other facilities, they are not responsible. And another challenge that we get with this is that these medicines, when they come, they are not given with the pool system. They are using the push system. That means the donors will be able to pack the medicine that perhaps you need this, and they will give it to you. And sometimes it comes not according to your need. For filariasis, in Zara, while there is no filariasis, you see, these are the difficulty people get. Actually, you have to send them to Upper Nile. And then sometimes the medicine come late. When they come late, they are almost expiring or they have already expired. And people don't benefit from them. Another challenge is you get the things, being it equipment. For example, you may get an ultrasound machine, but in your unit, you don't have somebody who can operate it. Or you have somebody, there is no power. Like medicines, the same thing. Medicines might come and they are not needed in that area. Or sometimes they don't get somebody who can really make proper management or use of these medicines. Sometimes there is over prescription because of poor quality of staff, sometimes, and also shortage of staff. And this is very common, perhaps even in the state. That's how the syndrome of malaria typhoid has come out. It comes with fever. They don't know what is the cause. Then they try. If it is not malaria, it might be typhoid, and they start giving the medicine. In other words, people need to be trained. The health providers need to be trained, and the number should be adequate. These are the challenges that we always get. And of course, regarding the issues, I don't want to talk into details because this service in the different facilities, you get a lot of problems, especially among women. There are cases of bleeding and so on. I can summarize it in the sense that most of the challenges there is the high maternal mortality and the infant mortality. And there are so many causes that we can go through them. Perhaps this forum cannot allow us. Otherwise, we need to take precaution. How can we prevent these things? And all these difficulties, equipment or medicines, the health providers also needs one thing: financing. If there is financing, all these problems can be solved. What is down there that cannot be solved if there is financing? If you want a doctor, you can get him if you have got salary to give him. You want a special course, you give her salary. She will come every day to the services. So everything is around financing the hospital. Otherwise, the strategy, as far as I'm concerned, that I have got in the Ministry of Health is a very good strategy, such that if it is implemented correctly, we will have very good health services.
Thank you, Dr. Bono, for that. I think you're probably the right person to talk about that because you've been involved a lot in terms of management of health services, and you are even a former minister of health in Central Equatoria State. So when we come to the conclusions, which will be coming to in a few minutes, you will tell us about some of your recommendations, especially when it regards to the financing part and the human resource part. So Dr. Kandang, you will sort of wind up by just giving us an overview about maternal mortality, some of the causes, and the emergency services that should be provided and whether they're available, and whether there's actually human resource for what the state for human resource for obstetrics and gynecologic care is in the country. Dr. Kandang, before we go to our conclusion and recommendations.
Okay, thank you, Dr. Ann. And quickly, let me say that in South Sudan, currently, as mentioned earlier by one of the members on this discussion, the maternal mortality rate has come down from 2,054 per 100,000 live births to around 780 deaths per 100 live births. This is considered as a significant improvement, but it is still a bad situation as compared to the maternal, to the regional context. Now, most of the reasons that lead to really these deaths are really due to postpartum hemorrhage, which is bleeding of a woman after delivering a baby without any immediate help to transfuse her with blood that can lead to loss of life. Now, the major causes or the main contributing factors are the fact that our blood banks are always without blood in them, although they are called blood banks. They are empty, no blood to be used on emergencies, such as in cases of maternal postpartum hemorrhage. The problem of having no blood in the banks is really related to some of the traditions and cultural beliefs and mythical beliefs also, that donating of a blood would lead to becoming impotent or to becoming reproductively non-viable. These are some of the things that make some of our communities to avoid donating blood, even to their own relatives. And this becomes a situation where the healthcare workers cannot indeed be able to do anything beyond watching a woman bleeding to death. Now, some of the emergencies that are happening, of course, we might know that every obstetric situation is an emergency situation because it can change from any time to hours that you can never expect. And therefore, it is expected that people are to be prepared for any outcome, for any emergency that can come. However, most times our health facilities are not having emergency units that are well set up for those responses. And if any, then there may be no personnel to be there, just because of what we have heard many of us have talked regarding the lack of motivation or the lack of proper payment for our healthcare workers. The other issue is also that at the moment we do have shortage of personnel, like my senior Dr. Bono said. Currently, people are using associate clinicians that are being trained to help in terms of obstetric emergencies. And these associate clinicians are a kind of a cadre being upgraded from either a nurse or a clinical officer before they are given specific training on emergency obstetrics and surgery care, so as for them to be able to work in the county hospitals to provide basic surgical interventions. Of course, we do have specialists in obstetrics and gynecology, but as experienced by the pediatricians, not all of them are within the hospital. Some of them have gone out of the government employment, basically to look for making of ends to meet. So, what be the challenges faced? We see that in the real situation, on my own experience, the major challenges are probably experienced by any of our colleagues that worked in the services for women, including the mentioned lack of blood, And of course, also sometimes we have power shortages for the facilities. And of course, due to the poor remuneration, there would be sometimes no personnel. I mean, you might be intending to do something, and then sometimes you will end up with the lack of one of the team members, and then therefore the work cannot go on. Sometimes we could be referring from Juba Teaching Hospital, hastens to be done operations in Juba Military Hospital, which is very strange because we should expect all referrals to come from other facilities to Juba Teaching Hospital. However, with the challenges that we have talked about, sometimes it becomes difficult to provide services in the Juba Teaching Hospital. Now, I believe that um, most of our people that are interested in training need to be trained. However, sometimes our senior colleagues or the consultants may not be there to provide training to the junior colleagues, like in Juba Teaching Hospital. So turning the facility that is considered to be for teaching becoming more or less a name only, not really the function of the teaching hospital happening. That's why at the moment one could be afraid of some of the new MOs or medical officers that are coming out from the training in the facilities without having hands-on experience or skills training. Most of them have, signed out of the unit, like for maternity and obstetric unit, without even doing a cesarean section. That is a very terrible thing to our young doctors. So I do think that we need to be prepared to deliver quality care to our clients, and of course need their cooperation and consent quickly when we needed any emergency donation of blood. This is mainly to shorten and to prevent the loss of lives due to maternal bleeding. I think let me end here before the conclusions and recommendations. Over to you.
Thank you so much, Kandya. I think you have actually emphasized on some of the things that are an issue for us, and I think the constant thing that keeps coming up is human resources, especially with the lack of motivation, even in terms of salary, and the fact that we are not even really developing our human resources for health well when it comes to our teaching hospitals, which where our students are not exposed to all the specialities that they need to be exposed to. So Dr. Bono, we will be concluding in a few minutes. So if you could please unmute yourself and give your conclusion and recommendations in 2 minutes, and then Dr. Kandang will then give his conclusion and recommendation. Dr. Bono, conclusion and recommendations.
Thank you. Well, Dr. Khan has talked about most of the causes of high maternal mortality rate, but fortunately it is coming down, as he has mentioned. He is correct. There have been a lot of efforts being made. This is because of the plan, the strategy, and the plan is there in the Ministry of Health. We need, as a nation, and the government in particular, improve to implement that plan that they made. Because if it is implemented, it will solve the problem of South Sudan, and it will having very low maternal mortality rate. And this will be a sign of development, a sign of improvement of economics. Because of a mother in any community and in any country, and the strategy. There is one we have mentioned here. If there is money, there is always a solution. Being it a retention of the health providers, being it training the people, being it encouraging people from diaspora to come, as Dr. Winston was saying, it needs money. So if there is this money, then the second thing will be proper management of this fund. Because I remember when I was in the college, nobody taught me hospital administration. This is what we have ignored in our teaching. We need to think about it. Either we give it to our students, or if we train this card, as I find it now in the system coming up, because management is different from clinical work. It needs somebody good who will be running the management, because it is not only the clinician alone who can run the hospital. It needs also the supportive staff in the administration, storekeepers, all these, the logistic officers and all this. These are the things that we need. If we have them, we will improve our system. So I appeal to the nation, those who are in position of the fund, to increase the financing of the hospital. According to the recommendation, is it a budget declaration or whatever it is, in any country, 15% of the budget of the country is supposed to go to health. But I remember the highest that I know about that has been approved by our legislative assembly was 2%. This is the highest figure I got. Maybe it might have been down there, but I don't know. But the highest that I can remember is 2%. What can 2% do with all these difficulties that we are facing? And then we ourselves, we have to be committed. And also the social education, the knowing how to live good life need to be taught to the community. And this is the responsibility of the elders and of the sociologists. Thank you.
Thank you, Dr. Bono. What I have garnered from what you have said is that our Ministry of Health actually has a very good strategic plan for healthcare for the country. So we have documents, we have policies. However, what we are lacking is leadership and management and financing. And with financing and leadership, then we are capable of doing all that is needed to do to improve the healthcare system of our country and thereby decrease morbidity and mortality related to most of the preventable and avoidable illnesses that are facing our people. So Dr. Kandiang, if you can please also give your conclusion and recommendations.
Thank you, Dr. Ann, and thanks to everybody who has been following this discussion. In conclusion, I just want to reiterate that when it comes to our health, each individual is to participate in helping the clinicians provide the best they could. The notion of refusing guidance of a clinician for the best results of the management of the client need to be stopped. The doctors are just doing the best they could, and God is the final person to bring healing. So we need to change from today onwards in the negative thoughts that at times come to our mind and lead to having stupid decisions or acting inappropriately, and that can end up being a cause of danger to our lives. We are here to just promote the quality and improve good health. Doctors don't heal, of course. Therefore, I would like to say that those who are able to read and understand have to also pass the message to others. And I would suggest that this kind of activity or forum discussion need not to remain only on the internet platform. Let it get translated into physical activity and on the ground where we can go and provide raising of awareness and health education to our people. In terms of reproductive health, I would like to say ladies don't accept to carry their cross and being blamed as the problem. That is why there is, for example, no pregnancy. No, remember, it takes two people to tangle, as the saying goes, and therefore it also takes a man and a woman for pregnancy to happen. Thus, you need to get checked if there is any problem in reproductive system. You need to be both looked at, and then the problem can be identified, and both of you can be given the best advice to be provided. I think that's it for me from now, and I'm so happy and thankful for all the things that you are doing. Willingly, God will be helping us to meet again. Thank you very much.
Thank you so much, Dr. Kandiang, and I really appreciate you being on this forum today. Many people do not know, but Dr. Kandiang is one of my mentors, and he taught me when I was still an undergraduate in my electives in Juba, and I'm very grateful for that. I'd also like to thank Dr. Gassim, who left before, Dr. Justin, who was here before, and Dr. Winston for also attending. And I would like to appreciate Dr. Bono very much for being on this discussion and for talking about some of the issues that are affecting healthcare at the state level. And Dr. Bono has been a teacher and a professor to many of the doctors that you have seen on this discussion today. And we are so grateful to our teachers for bringing us this far. And we hope that we know that the knowledge that they have invested in us, we will also invest in future generations of medical practitioners. So to our audience, thank you so much for joining us today. We hope that you have been able to understand some of the issues and challenges facing our health professionals and facing our country in terms of the healthcare system. It is a work in progress, and we hope that with investment into healthcare, with increase in terms of budgetary allowance for healthcare, and with investment in human resources and training of leaders specifically for health system management, we will be able to actually get to the targets that we're supposed to get to. And the diaspora has also been given a message that we also need to go back and influence change in our country. And it is only through individuals deciding to make a difference that we can actually be able to improve healthcare for our country and our people. And so we appeal to the Ministry of Health to increase financing for healthcare, to help in training human resources for health, and to motivate our healthcare workers so they can be able to provide services for the people of South Sudan, and also to build the healthcare infrastructure. Because if I have the skills, but I do not have the equipment or the medicine to provide those services, then I will not be doing anything in terms of healthcare in my country. So thank you so much, Dr. Kandiang, and thank you, Dr. Bono, for being with us until the end. And we would like to thank all the people who are supporting this forum, and thank you so much for encouraging us for the work that we are currently doing. Please join us once again for our discussions next week on Saturday and our discussion on Sunday. We'll be having very exciting topics, and you can check out which topics we're discussing next week on our page on Facebook. And thank you so much for joining us today. Thank you, and have a lovely evening. Thank you, Dr. Kandiang.
Thank you.
And Dr.
Thank
Bono.
you, and bye.
Bye. Thank you.